Wiberg, and we really appreciate the fact that he's doing this for us. It has been a lot of information that has been coming our way over the course of the last few weeks, and it's a very fast-moving topic, as you all know. I'd like to thank a couple of people first, one is Vicki and Keith over at the Home Care Association of America. We appreciate all the help and support that they are giving us as a state organization. We'd also like to thank Coffer DMC for their ability to get us up and running with a webinar as soon as they did. I'd also like to thank our board. The Washington Home Care Association board has put a lot of time and effort, energy into all that they do for the state of Washington. And if you run into them at a networking meeting, be sure to give them an extra thank you. The other piece I wanted to mention is that Blooming with the Boomers is being moved. We obviously can't hold it at this time. We are looking for our new dates. Probably going to be in September, but keep an eye out for that. All further questions after this webinar can be submitted at www.wahca.org, and we will put them through the process of running them up the chain to get the answer. And it does take some time, so I want you to be prepared for questions to not be answered right away because it's taking us time. We've been in contact with DOH, and they've been a great support to both Jeff and I as we've been preparing for this. And I'd also like to thank Jeff and his team because they have put a lot of time and energy into this conference. So at this time, I'd like to turn it over to Jeff. He is a board member for the Home Care Association of Washington, and he is our state liaison. He is also the owner of 8 locations, the CEO for Family Resource Home Care. So with no further ado, Jeff Wiberg, take it over.
All right, well, good afternoon, everyone. I wish we could be meeting in person and under better circumstances. But nonetheless, we're excited to be able to share some of this information with you today. I want you to know that we received hundreds of questions as part of the registration process for this, and we've done our best to really include the answers to all of your questions through the course of the conversation. That being said, if there's time allowing at the end, we'll have some opportunity for doing some Q&A, and that could be done through the group chat function that's part of this Zoom product. And so if you have some questions, if you think of some questions along the way, it might be answered through the course of our discussion. But if it's not, we'll try to get to as many of those as we possibly can, time allowing at the end. So we're here to talk about COVID-19. And everybody knows, of course, that Washington State has been at the epicenter of this, and home care has been deeply affected. And so there's a lot of questions about what it is that we can do as an organization, what is it that we can do as an industry, what is it that you can do as individual agencies in order to be able to make sure that we're doing a good job taking care of our clients, keeping our caregivers anxiously engaged and employed, and what are the regulations that we're facing at this particular time, and what are the tips and tricks on how to be able to prosper past this crisis. So getting into it, I felt like even though this is going to be probably some review for a lot of you, I really want to share some information about COVID-19 because in my personal philosophy, this is best managed when it's fact over fear. There's a lot of fear associated with COVID-19, and at the end of the day, being in possession of more facts, more information is going to put you in a better position to make better decisions for your agency, or better to communicate with your clients and your caregivers and help them to understand some of the decisions that you're making and why it is that you're making the decisions that you are. So some of this might be a little bit review. Hopefully some of it is some new and enlightening for you. We're going to begin at the timeline of this particular crisis. So back in December 31st was when the WHO was finally notified by China that there was a bunch of individuals in the Wuhan province region of China that there was a bunch of pneumonia going on, and they didn't figure out what was happening. So investigators were deployed to the site and discovered that there was a new in the corona virus family, a virus that was appearing. It looked like it had come from a seafood market in Wuhan, which is a very large city there in central China. And it was a new type of coronavirus that we had never seen before. And so they classified it as nCoV, and it began to change rapidly. So starting on January 13th, so just 2 weeks after the first notification to the WHO, an individual from Thailand had just come back from Wuhan and contracted the illness, and then started to experience symptomology outside of China. Then in January 21st, there was a Washington State man, putting Washington on the map, a Washington State man who had visited Wuhan, China, that brought it into the United States, became the first recorded case, January 21st. Fast forward now to February 29th. That is when we experienced the first U.S. death associated with the complications around COVID-19. That was a 54-year-old man, again, here in Washington State. So when I say that we've been at the epicenter of this, it is absolutely true that Washington State has been on the forefront of the fight in this whole regard. Now, just 1 week ago, March 11th, the WHO elevates the status of COVID-19 to a pandemic level, and there's over 118,000 cases worldwide, affecting a number of countries. Just yesterday, West Virginia became the last state to report an active confirmed case. So all 50 states are reporting cases, with Washington State, unfortunately, having the dubious honor of having the most cases in the United States right now, including the most deaths. So this has all happened very, very quick, and there has been an immense amount of response. We've seen it from the public, from the government, from the stock market, from healthcare, and this has all been happening extremely rapidly, and it is changing on a day-to-day basis. And so I know that you've probably been inundated with a lot of information, potentially misinformation, and not much of it has been directed solely to us as an industry. And so that's what we've attempted to do today, is to really kind of take some of this and make it all about home care. So how does COVID-19 compare against maybe some of other viruses? This is something that I think would be helpful for folks to understand as to the why we as a society are reacting the way that we are. So medical researchers assign contagiousness of a virus based upon its basic reproduction number. This is represented by an R naught score. And this R naught score is essentially how many people are likely to be infected by one sick person. So a score of 1 means that you're going to transfer the illness to one other individual, and it's going to remain a fairly flat kind of an illness. If it's less than 1, then a virus would die out on its own. It might have an outbreak, but it would go away on its own. But if it's greater than 1, then the virus has the possibility of going from an outbreak to an epidemic, and then finally to a pandemic in terms of size and scope. And so the score for COVID-19 is 2 to 2.5. So working with the highest here, 2.5 people, means that for every sick person, on average, they're going to infect 2.5 other people. That means that this can spread pretty rapidly. Now, if you look at this against some of the other communicable diseases that we have faced as a society, it's quite a bit less than measles or mumps or SARS or rubella, polio, smallpox, etc. The other factor here, though, is the mortality rate associated with each of these diseases. We're not nearly as it's not as deadly as SARS, for example, because SARS was spreading faster, or had the potential to spread faster, and the death rate was about 10% for SARS. So not a good comparison. The best thing that I found to try to really compare this against is the 1918 flu pandemic, that's sometimes referred to as the Spanish flu, because it matches both the mortality rate as well as matching the communicableness of the disease itself. So looking at what if this were the Spanish flu again, let's look at that for just a moment. And by the way, before we go there, just the seasonal flu, it's been, I've heard and even said myself that, well, gee, what's the big deal? You know, the seasonal flu kills 600,000 people a year. And here we've had less than 10,000 deaths worldwide associated with COVID-19. Why this level of panic? And it really does come down to some of the mortality rate components, because the seasonal flu has a mortality of less than 0.1%. The reason why the numbers are so high is because it has such ubiquity throughout all of the world. So if COVID-19 were to do that, its mortality rate is quite a bit higher. So it's 0.5 for those at 50 years or younger, but it's 8% for those over the age of 50. That's why you're hearing a lot of the details around, you know, keeping the elderly and vulnerable out of the pathway of this particular virus, is because it's close to 1 in 10, and that's a pretty high mortality rate. So this comparison against the Spanish flu, assuming that we're dealing with the same kind of a circumstance, the Spanish flu ended up infecting 27% of the world's population in 1918. That is a lot. If we translated those numbers, that means that there's going to be over 2 billion, 2.03 billion cases, which would result in 51 million deaths. That's over 2 million deaths here in the United States alone, if we were to let it run its course. That, my friends, is the why we are engaged in such drastic and quick response measures to try to stem the spread of COVID-19, is to just really avoid the mortality possibility that this particular illness could represent for the community at large, especially amongst the community that our industry deals with on a day-to-day basis. So is there hope in sight? Well, if you haven't paid attention to some of this news, clinical trials began on a possible vaccine here or in Seattle, here in Washington. That began on Monday. There were 4 people that were inoculated on Monday, 4 people on Tuesday. So this is hot off the press. And this represents an approach to try to get through the process of clinical trials is it can be lengthy. There's 2 phases to that. There's a safety phase, which can last up to a year, and then there is a efficacy phase. Now, the goal of these companies is try to fast track to go from the safety phase into the efficacy testing fairly quickly and be there within about 45 days from now. And that there is a planned application to the FDA to get approval to be able to go from safety to efficacy, so we're not having to wait a year before we're even measuring the efficacy of the treatment that's been developed. And by the way, this news for this Seattle test site is only one of 8 companies that have announced vaccine research, and one of 8 approaches that is being taken to try to stem the flow. The hope is that we would have a workable, effective vaccine by summertime. Whether or not that occurs is going to be up to these men and women of science who are developing these vaccines. But there's another way to be able to combat this, and that is to slow the rate of contagion by social isolation, which is a policy that was tested in China and has had great effect in China. And that's one of the reasons why a lot of the rest of the world has taken those same exact steps. So we're trying not to have a repeat of the 1918 flu pandemic. So some Washington State facts. This is fresh, hot off the press as of today. There are 1,012 confirmed cases statewide. Every county within the state does have a confirmed case, and that has resulted in 52 deaths here. The goal of wanting to work through social isolation, it really has a couple of functions. If it slows the curve associated with the pandemic, what we'll end up doing is saving ourselves the cost of having the number of cases overwhelm the healthcare system capacity. So we're seeing a lot of the hospitals in Washington State describing how there are no more elective surgeries going on. They're trying to send people home, get people out of the hospital so that we're preserving the capacity within the hospitals to be available for the most critical conditioned cases. And herein lies a little bit of the value proposition of home care, that as we can continue to communicate and educate the systems around us to help them identify the fact that we are pre-acute, meaning that we prevent hospitalizations, that we're preventing the secondary and tertiary problems associated with other disease processes or comorbidities, and we're keeping those folks out of the hospital. We want the community to realize that it's good public policy to work with home care so that we can be part of that solution of making sure that our healthcare system capacity stays available for dealing with this particular pandemic. Here's some confirmed cases by age and gender. Bear in mind that most of the testing that has been done in Washington State thus far has been for those that have been exposed or those in high-risk situations, and only 1 out of 14 have come back positive. So at the end of the day, our fear has led us to believe that, oh my word, somebody coughed and I was in the same room, I'm surely going to die. That kind of reaction is maybe a little overwrought in the fact that we're getting a lot more negatives than we are positives associated with this illness. And these details are available right on the DOH website, and they update it every single day. So some symptoms comparison. I know there was a number of questions that came in about, okay, well, how do we do symptoms checks between the common cold and the common flu and coronavirus? So first, we need to understand that corona does not necessarily make you immediately deathly ill. So somebody can develop the symptoms associated with coronavirus at any point between 2 and 14 days after contracting the illness. So that's why there's this mandate to secure in place if you feel like that you have been exposed for 14 days, is because that's how long it could incubate before you're seeing any of the symptoms. Secondly, a CDC study on about half the cases in China, which is about 40,000, by the way, a little more than 40,000, showed that 81% of the known cases were actually classified as mild. So what does that mean? It means that just because somebody gets coronavirus does not necessarily mean that they're going to become really ill at all anyway. We don't want to necessarily make people panic unduly, and recognize that if they have some of the symptoms like a dry cough or a fever, they need to treat it as if they have coronavirus and just secure themselves in place for 14 days. So the common cold, this is directly from the CDC. Here are the hallmarks of a common cold: the sneezing, the stuffy nose, the runny nose, the postnasal drip, the watery eyes. Those kinds of components are typical of the common cold, and there is a lot of cold going on right now. This has been part of the guilty party for why we have so many false negatives. And the ones that I mentioned out loud are the ones that are distinctly different from COVID-19. The flu is a little bit harder to distinguish between COVID-19 and the seasonal flu. There's fever, which matches, a cough, which matches, a sore throat that can match. But then you typically will also get the runny, stuffy nose, the muscle or body aches, headache, fatigue, and in some cases even vomiting and diarrhea. That is all associated with the seasonal flu. We have not seen those kinds of symptomologies following COVID-19, which has a fever, cough, shortness of breath. Those are the 3 main symptoms that the CDC says that is your sign that you've got a potential to have COVID-19. And so this is kind of some of the screening criterion that you can use directly from the CDC when you're talking with caregivers or office staff or even clients as to whether or not you're screening against the common cold, seasonal flu, or coronavirus. Not saying that you can't have both at the same time, but this is the distinction between the three. So how does coronavirus versus home care going to matter? So trying to now shift from this general overview of coronavirus and now really talk about home care and how we're going to be able to deal with this. So before I go into some of the state-specific stuff, I'd like to mention a few things that are happening on the federal level. The White House issued a couple of days ago a initiative that they're calling 15 Days to Slow the Spread. It's the recommendations that we've already seen put into place here in Washington State. The idea of social distancing, the idea of not going out to congregate locations or social activities that are more than 10 people, the idea of avoiding places like bars and restaurants and those kinds of things. This is something that we're already dealing with in Washington State, but this is something that's now being recommended on a national level. And working from home when possible is something that is also being recommended. You can get a little more detail on this particular program by clicking on the hyperlink. Schools being suspended, working from home with possible, avoiding social gatherings, all this has been part of that program. HR 6201, which is under consideration right now by Congress. It started out in the House, was passed by the House, got it kicked over to the Senate, made some edits. The Senate kicked it back over to the House. It's up, and it's expected to potentially pass and be on the president's desk by Friday of this week. So this is a pending legislative action, and it kind of brings together several acts that had been being considered over the past couple of weeks, and are referred to as the Families First Coronavirus Response Act. This is being responded to quite vehemently across several industries, but certainly across home care around the United States. A little less here in Washington because some of the things that it provides for, we already have, like paid sick leave it becomes a mandate to all employers to offer to their staff, and family medical leave benefits that are similar to regular FMLA requirements, but also apply to employers less than 50. So folks that are not used to administering some of the FML components would then have to be able to administer them. Now, there are some tax credits that may be available that would go against your Social Security, the employer portion of the Social Security taxes that you pay on the 941 on a quarterly basis. But that is only going to be made available to a limited number of employers based upon your size. And some home care agencies on the call, it will not apply to. And so there won't be a way to be able to recuperate some of those costs, but smaller employers may be able to do just that. The feds did expand some unemployment insurance benefits for displaced workers, which is essentially a federal match dollar that goes out to the states. It does require that all COVID-19 testing be done at no cost. And that is a question that has been coming up quite a bit. If there's testing that's required, who pays for it? An increase in the FMAP funding. So this is the funding that states receive for medical services under Medicaid in each state. So this is kind of an emergency FMAP funding to help individuals who might otherwise have a lack of access to care because they're under the Medicaid umbrella, and some providers don't want to work with Medicaid because of low reimbursement. It also expands some meal supplements, which is included under the Older Americans Act. So Meals on Wheels, those kinds of programs get their money oftentimes through the Older Americans Act, and it's pumping some additional funds into that world. I've got a lot of questions about PPE throughout the registration process here, so we want to talk about that for just a moment. Now, first off, you need to understand that OSHA does require all employers to provide PPE to your employees if it is that we're requiring them to use it as a part of their job. So we're talking about gloves, we're talking about potentially masks, we're talking about even hand sanitizer. Those kinds of things could become something that we are under obligation if we're asking the caregivers to utilize this PPE, especially under the COVID-19 infection control protocols. We have to provide those items. And so this is directly out of the OSHA standard. And there's also this general duty clause, oftentimes referred to as kind of the catch-all for OSHA, that requires us to make sure that we're furnishing to each worker employment and a place of employment which are free from recognized hazards that are causing or likely to cause death or serious physical harm. So this particular clause does put us under some obligation as home care agencies to be very, very, very cautious about putting a caregiver into a circumstance where there is a known infection for COVID-19. If you do so, you could be held liable because you are going against the general duty clause. And the reason why I'm going to say that, and this is a little bit of the opinion of Jeff Wiberg here, because some might argue, well, but we're healthcare. These people need our care, therefore we're exempted from the general duty clause. The question becomes, well, is there another way for these individuals to receive the kind of care that they would require otherwise? If the answer is yes, then our duty becomes getting them into that kind of a facility, such as a hospital, to receive their care if they are a confirmed COVID-19 case. Us mandating our employees to go into that environment, we could end up being liable, especially if they contract the illness and, heaven forbid, die. That would fall under WAHCA as being a reportable event, and it would go against your workers' comp for sure. So wearing a face mask, the CDC recommendation is that you wear it if you are sick. If you are caring for someone who is sick, you ask them to wear a face mask. If they are unable to wear a face mask, then a caregiver should don one prior to coming into direct contact, defined by the CDC as being in the same room with the sick individual. So this idea of running around everywhere with an N95 mask on is actually not consistent with the recommendation from the CDC. The masks are for the sick people, not for the healthy people. And then the point has been made, well, they're all gone. What do we do? So doing my own little research, getting on the list with suppliers is imperative that you do that now. There is the possibility that some emergency stores of PPE may become available. However, the conversations that we're having with the DOH indicate that that's going to go in terms of priority based upon the acuity level. So it's going to go first to the hospitals, then to congregate living like SNFs. Then eventually it might make its way down to home care. However, we shouldn't count on it. So my personal recommendation would be get on the list. I noticed that there are several vendors, even just on Amazon, that are proposing that their stocks are going to be made available by the end of the month. So we're less than 2 weeks away from that. I would say get in line so that you're getting some of that information available sooner rather than later. We are advocating for home care to be included as an essential service for PPE, but that is a noisy conversation, so I wouldn't necessarily bank on it. One of your best defenses here is to provide education to your employees. So Home Care Pulse, Care Academy, mycnajobs.com, Navon, they're all promoting free caregiver education about COVID-19 and helping people understand exactly what is the right thing to do in caring for their current clients, caring for themselves, caring for their personal families, helps them to kind of separate fact from fiction and make good decisions with regards to PPE. One of the problems that we've already begun to experience quite a bit is the N95 mask, for example. People are walking around with them and changing them out every single day, even if they're not being exposed. And that's a waste, essentially, of a mask that could otherwise be utilized in a more high problematic situation. The symptoms checks with your staff and clients should be utilized in all circumstances. And I think that modifying your care plans to include cautious social distancing should be something that you should educate all of your staff on, and educate as well your clients on, so that they recognize that it's not that our caregivers are now thinking that that our clients are a pariah, but that we're trying to help them stay safe and healthy by maintaining, where possible, being 6 feet away. And then washing hands. This is nothing new for us in the home care space. We've always had this kind of a regulation as part of our infection control policies to wash hands at the beginning, during, and at the end of every single shift, after touching your face, or under a variety of circumstances. Washing hands is one of the best defenses that we can render against COVID-19's transmission. And then if you're not able to get some of the hand sanitizer, there are several do-it-yourself recipes for hand sanitizer that are available on the interweb, and you could go grab one of those and package it up and distribute it to some of your caregivers if necessary. And then my last little editorial, and I'm sorry to put this in here, but this is a good reminder to us as an industry that if you didn't have backstock of PPE, be better prepared next time. This is something that as an industry, we should be always conscientious about maintaining some stock as a healthcare employer, so that when and if we needed to deploy it, we could. So some questions around insurance and liability. I got an opinion letter from a major insurance broker, Impro, who works with a lot of home care services to help understand what some of the liabilities could exist for home care agencies. And a couple things first, there's a concept called business interruption insurance, which is essentially a way to be able to recover some lost financial resources if and when a disaster were to occur. The most common example that is given to you by a broker is if your building burned down, you can't sell your goods or services anymore, the business interruption insurance would make up for the lost profitability of your organization during a period of time. Unfortunately, a pandemic is something that is explicitly called out as something exempt from most business interruption insurances. That being said, it does not preclude the OIC or Congress because of the disaster powers to mandate that some of these kinds of insurance products do pay out business interruption insurance. So the recommendation that I have is that you want to make sure that you're still tracking everything that you can to identify how COVID-19 has negatively impacted your business and revenue, profitability, or any losses that you're taking. So general liability. Let's say for just a moment that worst case scenario or a nightmare scenario, you have what would be reported as a healthy caregiver going into what would be reported as a healthy client otherwise, and lo and behold, you find out that the caregiver was actually infected with COVID-19, gives it to the client contracts it, client passes away, family wants to bring a wrongful death claim, etc., against you as an agency. Where is our liability as an organization lie? And there is a standard that has to be met for these kinds of general liability claims when it comes to disease transference. One, did you have any sort of protocol in place to screen your caregiver, screen the client, have some sort of attestation or certification that a caregiver was asymptomatic before being assigned to a location, that they had received the proper instruction or training associated with infection control? All of that is going to mitigate the component of this, which is ultimately negligence. If you don't do anything in the light of COVID-19, you could be held liable because of your neglecting to put into place best practice, things that are already required by our DOH regulations here in Washington State, for sure. And so if you want to avoid a wrongful death suit or a liability suit by either party, you want to make sure that you're putting into place proper protocols and then asking the right kinds of questions. One of the ways that I'm doing this as an agency is using my partnership with Access Care, who provides our point of care software. And Access Care is developing a kind of a symptoms check or a fit for duty test that can be done at the beginning of every single shift, so that caregivers have to certify that they don't have any of the COVID-19 symptoms at the beginning of every shift. And that, even though technically, yes, they could lie, at the end of the day, it demonstrates that we are trying to follow our own infection control protocols, and we're trying to keep our clients safe. It makes for a good story to the clients, makes for a good story to the caregivers, and certainly protects us from general liability. Then also having policy and procedure in place will also help to protect you against that negligence claim that can come your direction and create a negative situation for you. I've already mentioned this one, but workers' compensation liability does exist here. We had already several questions across the state about, well, hey, if we have a known COVID-19 case, do we have to take it? Or let's say that one of our clients develops a known confirmed case of COVID-19. Do we still have to send our caregivers in to care for that particular client? Or would we be running risk of being accused of patient abandonment if we decline to service that client? And so this is where your policy and procedure associated with infection control, especially that catch-all of the general duties clause within OSHA, can help you establish a policy as an agency to say, if you develop a communicable disease that is likely going to render my caregiver in jeopardy, we will have to cease services immediately. I don't see it any different from a scenario that we are already very familiar with, which is that a client is abusing our caregiver or threatening the life of one of our caregivers, whether they are cognitive or not. We are not under obligation to maintain care in those circumstances. So to avoid a patient abandonment situation, you would want to make sure that they are escalated in terms of their care if it is that they are so acute that they cannot function without a caregiver under that circumstance. But you could be held liable for by a caregiver who then contracts COVID-19 if you knowingly place them into the home of somebody who has an active case of COVID-19. And that falls under workers' comp. Can impact you there. It could also impact you on a liability standpoint because they could bring a suit against you. There are also discrimination issues that can come up. Because we're the hotbed here in Washington State, we've had tempted individuals who say, well, if somebody's of Oriental origin, they could be from China, they could be traveling to China. We're not gonna employ them, or before I make an offer of employment to a caregiver, I'm going to ask them health-related questions. Those are all prohibited behaviors. You can ask for a symptoms check after the offer of employment. You cannot ask it before and contingent upon their answers for employment, because now you're falling into discrimination issues. So that could open you up for some additional liability through the EEOC or the Human Rights Commission, or even on the plaintiff's side of these kinds of discrimination issues are coming up. I will say from some good news, if your organization is experiencing some severe trauma financially because of this, the SBA has opened up a significant amount of money for disaster assistance loans. And I have a hyperlink for additional information and application procedures that I've placed in here for that. So unemployment and paid leave changes here in the state of Washington. This has gotten a lot of attention. There's been some mandates by the governor's office and some rule changes that I want to make you aware of. So the first one is something called standby. So standby is a process where, okay, we have a temporary situation, usually 4 weeks or less, a temporary situation where we're not going to need you. We want to put you on unemployment insurance. However, standby, by the way, comes with some really good benefits for the employee in that they don't have to look for other employment. They can just literally be engaged to be waiting at home, collect their unemployment, and it's easy for them to get it They can even get a waiver of their 7-day waiting period. But this has traditionally only been available for full-time staff. And they have made changes to this rule to make it available to less than full-time employees. So this would make this concept available to caregivers, for example, that let's, heaven forbid, you don't have enough business to be able to keep your caregivers active. You could place them on standby, even at a reduced rate, and have a standby on the reduction, and give them some unemployment insurance benefits. If they are under some sort of quarantine, or they're doing the 14-day waiting period, that is also where the state has modified the rule to make unemployment insurance available for those individuals who are quarantining in place for the 14 mandatory days. That is how they're going to be compensated. And I've got the final rule up here. There is a possibility of full-on layoffs. And layoffs, you hear about a concept called the Warren Law. The Warren Law is probably not going to be applicable in this particular circumstance because there's certain thresholds that you have to hit. In Washington State, the threshold is 150 people. So you're not going to be running up against Warren if you're laying off, just a specific number of caregivers or even office staff during this crisis. But that would be it would be a strategy I would only recommend if you're anticipating it to be permanent, a permanent staffing change. I would first go with the standby furlough, which is beneficial to the employee as well. And that way, if all of this blows over and you're able to re-engage those employees within four weeks, you can bring them back in to your organization, no questions asked. And they're not going to be under an obligation to search for other employment during that time. The state sick and safe leave policies are still in place. Those have not changed, and you can see by the graphic, and I have this handout that you can utilize. These are 12 different circumstances where situations might be applicable, and where does the benefit come from, and kind of where you would engage that today. You can use the checklist provided, and here's the link to that. So a lot of questions came in about childcare because they heard that Jay Inslee during his press conference about shutting down the schools said we are going to mandate that the schools figure out a way to be able to provide for childcare provisions for healthcare workers. And this is something that the Office of Public Education or Public Instruction is under their mandate to do. As of this webinar, they have not yet determined how this program is going to work. However, the link that I've put up here on this page is where they're going to announce that. And whether or not we are included as a essential medical service is clear. We do know that this will also be at no cost to anybody who is working in the medical field, and and the way that this is going to work is they would then utilize the schools within the districts where the child lives. And you can see the rules and kind of rulings on this at that particular hyperlink. There are also other childcare resources and recommendations that could be found on this particular link, especially for those employers who may be considering the option of potentially putting together some sort of childcare option for their staff. As it stands right now, there are rules associated with that. How do you maintain social distancing and sanitization and hand washing and blah, 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 blah. That's where you would find all of those kinds of questions and issues. So some Washington home care regulation changes that I would like to bring up now. I think it's important for you to understand a little bit about the decision-making process during this particular time. So the Department of Health is the lead state agency, and they have formed what they call the Incident Management Team. It's a group of about 100 DOH employees that have been put together to manage this crisis for the entire state. They work in concert with the governor's office, and they also work in concert with the local jurisdiction, which is our individual health districts, usually at the county level. Ultimately, the final authority for day-to-day lies with the local health district. So if you're communicating about what needs to happen with your particular agency right now, the best agency to engage with is the county health department. The state of Washington's Department of Health only can work within the law as it presently exists. And the only entities that can suspend RCW and WAC is through the legislature or through the governor. Legislature has gone into they're no longer in session, so everything is going to be coming through Governor Inslee's office under his powers that are granted to him in the executive branch associated with emergency powers. So this IMT is going to be dealing with issue guidance on an implementation of emergency rules, which would include any modification to the rules that we are obligated to follow as agencies here in the state of Washington. The governor can make declarations. So for example, the one that he most recently issued was that there is a no visitor policy in place for any congregate living facility. No one can go into any one of those facilities unless they are a worker or if they are a supplier. And so question, are we a supplier? If it is that we are providing one-on-one care for somebody who is secured in place, but needs additional assistance beyond that which the ALF or SNF is able to provide, we could be considered a supplier in that case. So some areas to focus in on that we're monitoring very closely right now. The first one is prometric testing sites and fingerprinting sites have all closed. So there is an interim rule out that we are not under obligation to terminate or lay off caregivers who are unable to get their fingerprinting done within the required amount of time per the BCCU rules. Moreover, if you have candidates who are working for you and they've been enrolled in a HJ course or a NAC course, and they're getting close to their 200 days, normally you'd have to lay them off at that 200th day unless they have passed their test. Well, with the testing sites closed, they have suspended all of the rules associated with these two requirements, and you are able to continue working those employees up until midnight, April 9th. That is the new deadline. It doesn't mean that the requirement goes away, mind you. It's that the new deadline is April 9th. My personal advice is make sure that you're engaging early in the process when prometric sites or the BCCU background fingerprinting sites come back open, because the later you wait towards the April 9th, I think you're going to have a hard time getting those people scheduled for those tests or for the fingerprinting, and you're going to put yourself in a position where you're laying people off as of April 9th. The in-person rules surrounding supervisory visits and admissions has gotten a little bit of attention. So DSHS has already issued some guidance saying that we're suspending the rules around supervisory visits and in-person admissions. And we're allowing for all of these things to be taking place over the phone for the next 2 months. Now, in talking directly, in fact, just in the last 2 hours with the DOH, we made them aware of that fact, and the DOH says they did not do that in concert with the DOH. And so the DOH is now taking that recommendation and they're escalating it to the IMT and are considering that as something that we might be able to do statewide. However, those two ideas are not actually in concert with the DOH regs as of this moment. So in other words, this is an example of when one hand doesn't know what the other hand is doing and they maybe spoke at a turn. So the way that this decision-making process goes, again, with DOH being the lead agency, they are the ones who have to make that call as far as the IMT team making that call. Individual state agencies cannot actually modify the rules on their own. Some additional issues, if you identify additional issues that are maybe problematic for your agency, saying, boy, we need to suspend this rule or this rule because COVID-19 is making it impossible. We would like you to escalate those up to WAHCA, any member of the board in particular, and we will escalate those to the IMT. We've gotten some education on exactly how to communicate with that team and how to kind of go through that process. So we're advocating for some of that as it presently exists right now. Some additional resources that I want to make you aware of. Here's a bunch of links. I recognize that there is an overwhelming amount of information, and it's hard to necessarily understand exactly what is specific to home care versus every other employer versus other healthcare entities and not applicable to us, et cetera. Or, boy, I don't have an emergency response plan, or I don't have infection control plan, which you should have by now already. But let's just say that you still need some help on developing some of those kinds of policies and procedures. Here's some checklists that are available. Some of these have been put together by our national association. Some of them are specific to Washington State, and I've got a bunch of links in here that will give you some very direct guidance on where to go and where to find information that is specific to home care, or just to us as employers overall. And where do you find the right kind of information? The DOH did put out a guidance for in-home care services providers, and that can be found on the link on the lower right. And that document is full of additional resources and guidance as well. These are all things that that you can make available to you. And by the way, I just got a question on this. So the PowerPoint in its raw form is going to be made available. We're going to post it up onto the HCOA website. So if you log in as a member, it'll be available for you to download, along with all of the handouts as well and documents, sample communications, sample policies, those kinds of things are going to be available right on the website that you can log into. If you're not a member, we'll address that a little bit later on today. But these I think will be very helpful for you as you're running your agencies. So some policy procedure recommendations. This is also an answer to some of the questions that we've gotten through the registration process. How do we screen, and what do we do if we get a yes? What do we do if we get a no? So I want to address some of those. So first question: if a client has symptoms, you would notify your local health district. They would give you direction as to whether or not you would want to have that individual tested. It is not required that they get tested. They may voluntarily choose not to be tested. That is okay. That is their prerogative. If that is the case, one way or the other, they are under a mandated 14-day secure in place requirement. And whether or not you continue to serve them is up to you as an individual agency, because just because they have symptoms does not necessarily mean they have COVID-19, and just because they have COVID-19 doesn't mean that your employees are going to get COVID-19. However, this is definitely a decision that is at the individual level. I can tell you what I'm doing. If we have a client who has symptoms and we think that it's COVID-19, we are encouraging them to get tested. Otherwise, we're going to discharge from services because we want to protect our employees. That is just that is our decision of how we've made. I can't tell you necessarily what to do for your agency, but I think that it's important for us to be responsive with a policy and a procedure that we would follow, and we communicate that ahead of time to all clients. If a caregiver has symptoms, so you're doing screening and a caregiver says, yes, I've got this dry cough, then again, you would want to put them on a 14-day mandatory waiting period before they can work again, just to make sure that those symptoms go away. And I've actually got some information here on when you would allow them to come back to work and how that will work. If they refuse testing, you can't mandate it. You cannot mandate it of a caregiver either, even if they're an employer. But what you can do is make it to where they cannot work until they have either had a negative test or they've gone through the return to work protocols that I'll show here in just a minute. You would want to disinfect any high-touch areas daily as part of your care plans. That might be an adjustment to care plans that are in place right now. And that would include, banisters, bed rails, knobs, faucets, cutlery. I mean, anything that is common touched surfaces. This is something that should be part of the day-to-day home care world care plan at this point. When to discontinue home isolation. So I mentioned that, gosh, I don't know when I'm supposed to allow a caregiver to come back. So here's the direct guidance that is by the law. If you have had no fever for at least 72 hours, that is 3 full days of no fever without the use of medications that reduce fevers, and other symptoms have improved. So example, when your cough and shortness of breath have improved, and at least 7 days have passed since your symptoms first appeared. Those are the protocols that you would follow, or you receive 2 negative tests in a row 24 hours apart. These are the instructions that a doctor would follow, and here's a copy of the CDC guidelines that all physicians are required to follow with regards to testing and how they would report a full recovery of somebody who is either suspected to have COVID-19 or was a confirmed case. This is your return to work protocol right here. Make and follow your own policies. This is something that this is a Jeff guidance moment. Some of the guidance that we're looking for out of the DOH may not become available for, let's call it a week. So what do you do in the interim? Well, you can choose to follow the law as it presently exists, or you can do an emergency policy, follow your own policy, and then at survey time, you say, because of COVID-19, we instituted the following policies and we followed them during the interim period before we got direct guidance from the DOH. I am not saying that that's not going to result in a deficiency or a citation. However, we have it on, wink, wink, nudge, nudge type of guidance that that may be sufficient for us to do what's right to keep our clients, our employees safe. So an example of that is if you were to say, I'm going to suspend all of my supervisory visits for until we can for sure get that guidance from the DOH, because I don't want to send my office staff unnecessarily into the home to do a process that's kind of a check the box process. I'm going to do those over the phone. Write that up in your policy, follow it because of COVID-19, and then make sure that that is documented extremely well in your point of care software or in your client file, however you do that today. And then make sure that that policy also has an expiration date so that you're showing that you also have intent to go back to the original law as it presently exists. So some screening of your employees, testing. This is a big question. Can we test our employees? Clients are calling up and saying, do you test your caregivers before sending them out to the home, etc. So here's some information that could give you some language in talking to your clients, talking to your caregivers, helping them to understand where things are at. All tests must be ordered by a physician. So number one, we aren't in the position of being able to order a test yet. The statewide lab system as it presently exists in Washington State can test about 950 people per day. So there are some natural limitations. There is not a requirement by the DOH or by the CDC that limits the test to go to only specific individuals like high, low immune systems or maybe elderly individuals. There's nothing of that nature. However, there is gentle guidance to physicians that should be the case. So the physician is the ultimate decision maker. They can determine who they want to have tested, but they have to order the test. The recommendations for the DOH is for those with symptoms, patients over 60, and those with underlying medical conditions or those who are pregnant. That is the guidance. So one, use some language that you could talk to your clients about is, you know what, I totally understand why you would want us to be testing our caregivers right now, but right now the state is asking us to limit the tests for individuals under these circumstances, and there's a limited number of tests available, and there's a limited number of labs that can process it, and so we want to be respectful of what's going on in the healthcare world right now. And so what we're doing as an agency is we're doing symptoms checks, we're doing those kinds of components, training, infection control. Testing resources are just not widely available, but they are trying to make more labs up and running. Moreover, even when there is a positive test, there is no current treatment option, so it doesn't actually help you at all to know for sure that it's a known positive. Well, great, that means that you're going to follow the same exact protocol that you would do if you just had a suspected positive. So it comes down to the symptoms. If a caregiver or a client has the symptoms, you need to treat it like COVID-19 and just follow that protocol. That is the best option that we can give. Knowing for sure whether or not it is or is not does not actually help, because at the end of the day, there's no change in the treatment option. So some screening, we're starting to get some pretty out there worry. I need to call off my shift because, my former roommate's dog was named Bill, and I know a Bill who has COVID-19. It's the exposure, actual exposure has been defined by the CDC. Living in the same household as a person with a confirmed case of COVID-19, that constitutes exposure. Caring for a sick person who has COVID-19 does constitute exposure. Being within 6 feet of a person with COVID-19 for about 10 minutes or more constitutes exposure. Being in direct contact with secretions from a sick person, that's not supposed to be sick person, not pick person, with COVID-19, such as kissing, sharing utensils, those kinds of things, that constitutes exposure. Like I mentioned in the very beginning of the presentation, only about 1 in 14 of the already suspected group test positive for COVID-19. So it's not like you could look at somebody and boom, they've got COVID-19. I don't want to get into a xenophobia type of a situation or pretend that it's much more virulent than it is. The focus, therefore, should be on the symptoms, even with exposure. Restrictions are not in place. You just monitor for symptoms for 14 days. So the CDC says if you feel like you've been exposed, just monitor symptoms for 14 days. You can still go to work. You can still leave your home. It is only if you have the symptoms that they ask you to then shelter in place for 14 days. Some recommendations also from me. I think that every agency should categorize your client census by acuity and risk. This is kind of a triage, if you will. And this is if this really goes gangbusters and you guys end up, we all end up having a ton of our caregivers calling off, and we've got a lot more clients that need the care than we have caregivers to be able to provide the care. Having a protocol in place that says, here's my highest acuity level individuals, we will see them first. We're going to prioritize those shifts first. We're going to prioritize the staffing of those shifts first. And it shouldn't just be by acuity, it should also be by risk. And what do I mean by that is, let's say that they live in a facility, or if they have family nearby, they may be less risky, even if they're high acuity. Developing a policy around that. We have a sample policy that's in the document that you can utilize and just edit it to be your own. It's a Word document that you can edit. If you're going to do it this way, please document in your EMR, and then make sure that it's written into a policy so that you're not accused of some sort of discriminatory behavior. Leverage your software. I talked about the Fit for Duty enhancement that Access Care put into place. If I would get on the phone with your whatever software you have and see if they could do something similar, or make the switch in a couple of days, because that's so easy. Have an emergency response planning that includes if a client or caregiver tests positive, what are you going to do? What is your agency's rules if there's a known exposure? And there's some guidance on creating that policy here. You would call the local health district office, follow their instructions, monitor for symptoms, and you could self-quarantine for 14 days. You would make sure that you want to have a policy that addresses what your agency will do if you get a referral for someone who is showing symptoms or is a known positive. Ensure that your infection control policy addresses all of these protocols. And because this is not necessarily unique just to COVID-19, there are other communicable diseases that you're going to want to make sure that you're following the same process for each and every time, for the sake of just mitigating your own liability, if nothing else. And then addressing that patient abandonment elephant. Direct from the DOH, we heard the guidance that we as an industry are not under any sort of obligation to care for someone in their home that has a communicable disease. We don't have that obligation. It is not considered patient abandonment to keep our caregivers safe. So if it is in your policy that a communicable disease would be reason for discharge, remember we are not the last end-all be-all for healthcare. Hospitals are that. So we have the ability to hand them off to be able to receive the care if necessary. And I know I might be sounding a little bit stricter or heartless there. I'm not. I really just want to prevent this from becoming a more exacerbated issue. Prepare also, I believe, some resources for those dealing with what the CDC is now calling the STS, or secondary traumatic stress. This is all the stress and fear and anxiety that has been built up about COVID-19. There's some resources that they put together of how you could talk to your clients, how you could talk to your caregivers, how you could talk to your office staff. It's communication that basically says it's going to be okay. And here's some ways to be able to deal with that stress. If you don't have an employee assistance program, you can engage with the employee assistance program if you do. If you don't, this link will have some great resources for you to be able to deal with some of that secondary traumatic stress that's associated with this whole crisis. And then my final recommendation here is keep communicating, rally the troops, make sure that they are feeling supported from you as an agency owner. That's so key. Some prognostication for the future. The next phase for Washington State, if it gets worse, would be to shelter in place. And there was a ton of questions from a bunch of you asking, if that happens, will we be able to still send our caregivers into other people's homes? The best example I could give you is directly from the one that took place earlier this week in San Francisco area, where home care was expressly called out as being an essential service. So that allows for us to go out and see people in their home. We're trying to secure that kind of a definition on a federal level, and getting some modifications into the Family First Act that would assure that, but anticipating that's best practice. And we are also, by the way, trying to get that through the governor's office as well. We prepared a letter that we're going to be sending in to try to make sure that we recognize good public policy around home care. If this goes protracted versus the 15-day timeline here, we're going to have to think of more creative ways to be able to do what we're doing. And in my personal opinion, do what my agency has done, do some emergency planning, do some worst case scenario planning. What would you do to cut costs? What would you do if you're not able to get enough referrals to keep business going at the same clip that you have been used to? What are the decision-making criterion? And then communicate that with your staff so that they're not living in fear of an unknown. Emphasis should be on good infection control, especially as there begins to be what I'm calling crisis fatigue. People might start to be like, okay, this COVID-19 is just so, all right, I can't take any more of this. So they let down their guard. That's where education regarding good hygiene should be the hallmark of your process going forward. That's good infection control. This whole thing could end up being good for the home care value proposition because at the end of the day, where the real problem lies is in congregate living for the spread of these kinds of communicable diseases. And at the end of the day, we know that home care is the safest place for folks. That is something that needs to take place. How long will this crisis last? Well, there's a lot of opinions out there. Some of the better scientific minds are indicating that this could be going all the way through spring of 2021, where we're dealing with this particular illness making its way around the world. And so this is why I go back to that graph that kind of displayed that we want to take the possible huge spike and flatten it out and stretch it out over time, because that means that we're not going to be overwhelming our healthcare system. But I don't believe that in any way, shape, or form that we're going to be in a secure in place and social distancing and all that kind of stuff all the way through spring 2021. It just may be still affecting us as a society all the way through that period of time. We are going to continue doing advocacy work nationally and locally. HCOA is doing a phenomenal job at the federal level. Please participate in those calls for actions for the grassroots efforts as those come out from the national level, and we will do the same thing here at the state level. Because we're not at a legislative session right now, it's really going to be working with the governor's office and or the incident management team to be able to advocate for what it is that we need as an industry. And so we're going to try to funnel that through WAHCA so that we have a pretty consistent voice on how that should operate, and will represent well from that standpoint. And a word on the economy. You know, there's a lot of indicators that this is, you know, hearkening back to the days of 2008. And at the end of the day, my advice there is it's not 2008. The causation is extremely different. Our position in the world economy is significantly different. And a lot of the wisest people on Wall Street are pointing to a lot of really positive indicators that, yes, this could result in a recession, but it doesn't necessarily mean it will, because a recession by definition is 2 quarters of retraction in a row, and it may not last even that long. Right now, some of the folks are saying that this could end up having an economic impact just through mid to late summer, in which case it'll be a blip compared to the Great Recession that we experienced back in 2008. I could probably circulate some articles on that one as well, if folks are interested. So use the chat function to do some Q&A. I've got some up here that I'm gonna go through, and we've got just a couple of minutes to be able to do that. So we'll try to get through as many of these as we possibly can. So hearing from Marilyn, she says, so if we have a caregiver approaching the 200-day employment rule, we can keep them working until they can get a test date. Yes, Marilyn, that is the case. And that is the case all the way through April 9th at midnight. Either they have to have the test by that date, or you're going to have to lay them off, or there'll have to be another extension beyond the April 9th. But right now, we have all the way through April 9th. And she makes the point, I can hardly imagine that there'll be open test sites by April 9th. Well, let's hope that they are, because that's a positive indication for everything. But if they aren't, I'm anticipating that the governor's office or the IMT will be extending the date from April 9th to another future dated point. Got another one that says, an HR question for caregivers that are self-isolating because of pregnancy or other comorbidities, should we require a physician statement that confirms that they are being directed to self-isolate? You know, attendance policies are going to differ from employer to employer. You know, we've long had a policy in place that if you're out because you're sick, we require a physician's note after so long just to make sure that you're fit for duty. In this particular case, I could see there being a warrant for not having that kind of level of strictness, that you could allow for employees to come back under the CDC guidelines that I pointed out earlier, that they're symptom-free, or if they had symptoms, you know, this is how long since they've had those symptoms, and or go through the process of getting a negative test from their physician. You know, I think that we as employers, as good corporate citizens, should be being very empathetic towards any of our employees that do have pregnancy or comorbidities that make them nervous. But I would also point out to them through good education that home care is the best place to work. Aside from somebody who's already working at home because they're already a solitary worker, home care is about the best thing you could be doing to keep yourself safe. This is where good education could maybe help folks that are dealing with higher risk scenarios would become comfortable with their career as a professional caregiver. And she clarifies here that this is for someone that has no symptoms and has not been exposed. Yes, absolutely. I would not require anything in particular for them to be able to come back to work. So M. Gill says, is the slideshow going to be available for download? Yes, this will be posted up onto the HCOA website. And we can send out an email blast letting everyone know the exact instructions on where to go and where to click so that you can get not just the slide, but also all of the ancillary materials that kind of go along with this presentation and things that would help you to be able to formulate your policies, your procedures, and how you would respond, some best practices and kind of pulling together a bunch of information from a whole host of places to make sure that this is available. And the video recording too, you know, I didn't clarify with Amber if she was recording this or not. She is recording it. So the video recording can be made available. We can post that as well, assuming that the size is not prohibitive. But worst case scenario, we can put it out on a YouTube channel or something of that nature, make it available, upload it to that if you're interested in listening to it again or sharing it with other members of your team. Thank you, Jeff, and your team. You're welcome. This has been very helpful. We are in South Jersey. All right. And learning from those who are already dealing with this is invaluable. Thank you again. Yeah, I appreciate that, Andrew. I recognize that we had a few folks that were outside of Washington on the call today, and we are, yes, at the epicenter, and I'm hopeful that we are establishing some good best practice here in Washington State. And then I just got a note also from here internally from Family Resource saying that the Senate just passed the Family First Coronavirus Response Act. So that just passed the Senate. That's fresh, hot off the press. That'll be on the president's desk later today, it sounds. I want to make mention that we are going to be sending out a survey that is going to not only just say, hey, how was this helpful for you, but also to provide some instruction on how to ask ongoing questions and where to go as we continue to populate some FAQs or update you as additional mandates or additional gubernatorial declarations come about. You know, the direct impact of, you know, what's being passed right now by Congress, those kinds of things. We'll want to continue to get some of that information out to all of our membership. Pay attention very closely to HCAOA's weekly. That's having a ton of really good information in it. And that's really going to be the federal stuff. And then, you know, the Sean and the rest of the board here in Washington State will continue to try to keep us abreast of everything that's happening within the home care world for specifically Washington. Next one, N. Anderson says, I'm confused regarding the DOH guidelines for testing. Employees with symptoms, pregnant, comorbidities, etc., or testing people living in the same household or caring within 6 feet. So the recommendation right now is for those with symptoms or that are high risk. Just because you've been exposed does not necessarily require or recommend testing. So if you've been exposed, they recommend that you monitor for 14 days. Monitor for 14 days. Whether or not you as an agency just say, I want you to go home and monitor is up to you. It is not required by the DOH. You can still work, you can still go out and be in the community and so forth. You are just required to pay attention to whether the first symptom that comes up, that is when you are required to secure in place or get tested, one way or the other, to make sure that you don't have the disease, if that helps. Can you repeat just what just passed? So the Senate just passed the Family First Coronavirus Response Act. That is that federal law that we talked about at the federal update that was under consideration right now. That's going to provide some additional money for the Old Americans Act programs. It'll provide some additional Medicaid dollars. It's going to make the testing free for anybody who gets tested. It'll open up some additional resources for unemployment insurance. And the biggest impact to kind of folks outside of Washington State is the mandate for sick leave from employers, and as well as some FMLA-like leave benefits for even employers under 50 who traditionally have not been required to follow FMLA guidelines. That's always been the threshold, but it's now being extended below that, and it'll have some tax offsets for any sort of expense that you're incurring. That being said, here in Washington State, we've already had the Sick and Safe, which our employees have access to, and then the state has responded also with a through the Employment Security Department, the ability to go on to standby for any of these 14-day standby or furloughs. That will give them some unemployment benefit insurance. So that exists already in Washington State, but now it's been passed federally. Let's see. Next one from Artie. Are we required to provide gloves, masks to all caregivers? Great question, Artie. So the operative word in your question is all. Under the OSHA requirements, you are required to provide PPE in circumstances where you are requiring them to use PPE. So let's get graphic. If you've got a caregiver with a bowel program, you're requiring them to use gloves to be able to take that shift. Therefore, under the OSHA requirements, you are to provide those gloves as an employer. So the problematic word that I have here is the word all. Your policies do not have to be that you provide them to all employees. It is just under the circumstances where you are asking them to utilize gloves or masks or whatever it might be. And in the case that the masks are not available, can they still continue to work? Yes, this is again kind of an opinion. If you've done your best to be able to provide the PPE and the PPE is actually out, the CDC does actually have some regulations around that. And it makes it available for us to say, I'm sorry, we don't have additional gloves, we're on back order. It doesn't mean that we have to stop doing the services. And then we have a comment here. We have our clients pay and provide the PPE. Any concern with that? No, it's not a concern. And the reason why is because you're under obligation by OSHA in order to be able to provide the PPE to your employees, whether that is through the client as part of your service agreement, or whether that is directly through you as an employer and you're billing for it anyway because it's built into your bill rates. Either way, it's you provisioning the PPE on behalf of your employees. So I have no problem with that. Any other questions? We've got a couple minutes left. If you have any questions, just find the chat function at the bottom of the Zoom, and we'd be happy to answer anything that you've got. So here's a question. If you have a client using a nebulizer, what should the protocol be? And that is an important question. So a nebulizer, right now, unfortunately, nebulizers are a problematic device because if you get an infectious disease within a nebulizer, that's almost 100% transmission And so if you've got a client with a nebulizer, you have got to be using PPE in that circumstance. CDC requires facilities to utilize full PPE when working with the nebulizer. It's not been traditional to require full PPE in the home environment because technically you're around the germs that the individual's accustomed to, so there's less incidents associated with nebulizer related diseases. But that's a sticky situation in this circumstance. I'd be hyper careful about the kind of caregiver you're putting in that circumstance and what their training is, as well as whether or not they have gloves, mask to be able to wear. Do they have to be in a full gown or a negative pressure suit? I wouldn't worry about that in the home environment, although that is being required, I think, right now in the hospitals if there is known COVID-19 in the hospital. Next question is what to do with caregivers who are healthy but refusing to take shifts because they are afraid. Great question. This one's a toughie. I personally am taking the stance of let's provide education, because the more education that they receive, the less they're making the decision around fear versus fact, and helping a caregiver to understand that if you're a healthy individual, home care is about the safest environment for you to be in right now because it is one-on-one care. I'd potentially work with the individual to get them one client that they're comfortable with, one schedule that they're comfortable with. But if they're saying, even then, I refuse care, I want to be able to self-isolate, then I admit that I would fight their unemployment claim, or I would fight the experience rating hit that we would receive as a agency. But you can't force an employee to go to work. At the end of the day, they always have the right to be able to refuse work, especially under the circumstance where they feel it's unsafe. But I would definitely be fighting their unemployment claim, which could get their attention to come back. Okay, next question is, if you decide to do a phone intake assessment, how does that impact OSHA requirements, such as the safety check of the home, making sure that the home environment is safe for caregivers before sending them in? OSHA does not require you to have eyes on. So it does require you to make sure that there is a safe work environment for your employees, but that safety check can actually be done over the phone. Yes, in that circumstance, you are relying upon the honesty of the individual that you're talking to, but under these COVID-19 protocols, I think that you'd be in a very defensible position, both from a workers' comp standpoint as well as from a general liability standpoint, because you have the policy to conduct the assessment or the supervisory visit or whatever that way. There's also other mechanisms that you can deploy for technology use. The possibility that you can do a video phone chat, have them walk around the house, or those kinds of things to be able to make the same kind of assessment that you would normally do if you were physically present in the home. Take pictures. Almost everybody has that kind of technology available at this point, and so I would leverage that as you can. Next question is my understanding correct that your advice is do not accept COVID positive clients to protect your employees? Yes, it is. That is my recommendation. That is my personal recommendation. There is no law against you accepting a COVID-19 patient, but it is my personal stance that if it's a known positive, we're not going to be asking our caregivers to go in that circumstance, both from a liability as well as just a employer standpoint. It philosophically doesn't match with what we want to, who we want to be at the moment. If a caregiver has been exposed to someone with COVID, they are required to monitor symptoms for 14 days. That is correct, but not necessarily to self-quarantine unless symptoms. That is also correct. Are we required to notify clients or others that they may come in contact with that this caregiver has been exposed to and are self-monitoring? No, you are not required to notify a client unless a caregiver goes symptomatic, then you are required to notify the client that they may have been exposed. But you are not required to notify someone who has possibly been exposed and who is being monitored for symptomology. And that is directly from the health district, because I had that question. You're welcome. Any others? If not, we're right at time anyway. Oh, let's see. Have been exposed. Required to notify a client if they've been exposed. Oh, so if a client, if a caregiver goes symptomatic and you've identified that they went symptomatic having served a client within the last 2 days, you would be under obligation to notify the client that they have been exposed, yes. Only if the caregiver has gone symptomatic, and preferably after you have had them tested. But a caregiver can legally refuse the testing, in which case you have to behave as if they were tested positive. And then what you're asking or advising the client to do is monitor yourself for 14 days, see if there's any sort of symptomology that comes up. All right. With that, I just want to end with just a quick disclaimer. You know, I'm absolutely happy to do this today. I'm happy to help out the industry. I'm a bit of a data nut, so I like studying this kind of stuff. I like being able to make data-driven decisions. But I would ask that you don't inundate me personally with a bunch of questions or anecdotes. Please use the process that we're going to be sending out as a follow-up from WAHCA. That will provide the opportunity to be able to ask some questions, and that way it's more than just one person who's trying to filter that. And remember that I'm not necessarily an epidemiologist or anything of that nature. I'm not an attorney. I'm trying to represent my best understanding based upon the information I've garnered directly from all the folks that I've been working with. But I'm just offering myself as nothing but more than an industry advocate. All the materials will be available in the member section of the HCOA website. If you're not a member, we encourage you to become one, because this is the reason why you should be a member. If you're a home care agency and not a member of HCOA, you're stupid. And I apologize. That is, yes, my opinion once again, but I believe that very wholly and completely. And learning on all the benefits, not just these benefits, but learning about all the benefits that HCOA has to offer is available right on the website. And remember that WAHCA is the Washington chapter of HCOAW, so it's not like or HCOA. You don't have to join one or the other. It's if you join HCOA, you're already a member of WAHCA here in Washington State, or if you happen to be on the call from another state, that would join you to the local state chapter, wherever that may be. Thank you very much for your time and attention. Appreciate your questions. We love the opportunity to be able to help the industry out, and we'll keep an eye on all the continued progress as it moves forward. Bye, everyone.